Here we have a normal 12-lead ECG showing a recording of 2 beats from leads 1, 2 and 3, 2 beats from leads AVR, AVL and AVF, and 2 beats from each of the chest leads, with a long run of recording from lead 2 at the bottom of the readout, the rhythm strip. Looking at this ECG, there are a few points we'd like to emphasize and a few refinements we'd like to make, the importance of which will become obvious to you later. In the precordial leads V1 to V6, we see the dominance of the left ventricle producing deep S waves in the right-sided chest leads and prominent R waves in those more to the left. We'd like you to note that the transition from dominant S waves to dominant R waves in the chest leads normally occurs in lead V3 or V4. The transition at this point from an overall negative QRS to a positive QRS complex in the chest leads is termed normal R wave progression and reflects the dominance of a healthy left ventricle with a normal pattern of flow of depolarization around the chamber in generating QRS morphology. Looking at this ECG, you will also notice the perfect concordance in all the leads between the T waves and the QRS complexes. Those leads with overall positive QRS complexes have upright T waves, while those with overall negative QRS complexes have inverted T waves. Such perfect concordance between QRS complexes and T waves is observed in children and healthy teenagers, and when seen in middle-aged subjects is often referred to as a persistent juvenile pattern. For reasons which are not fully understood, however, in older, perfectly healthy adults, it is more common to see upright T waves in lead V2 and even lead V1, despite the dominant S waves in the QRS complexes of these leads. In the middle-aged to elderly population most of us deal with, a persistent juvenile pattern with inverted T waves in lead V1 and V2 is of no pathological significance. However, inverted T waves in the chest leads beyond lead V2 may reflect underlying pathology. In addition to their orientation relative to the isoelectric line, we would also like you to note that a normal T wave is somewhat asymmetrical in shape and tends to be less than half the amplitude of the preceding R wave in height. These points will come to the fore again when we go on to deal with disease diagnosis. Another ECG feature which we will discuss in some detail when we go on to deal with disease states is the presence of Q waves. We've seen that early left to right depolarization in the interventricular septum is the key to understanding the potential existence of small physiological Q waves in any of the left lateral leads, exemplified here in leads V5 and V6. We'd now like to refine your understanding of septal depolarization and physiological Q waves. As shown here, the interventricular septum is of course a three-dimensional structure. Depolarization of the septum does indeed spread from left to right, as we've seen in our two-dimensional schematics. But in 3 dimensions, you can see that this left to right movement also travels upwards and somewhat backwards from the lower part of the left side of the septum towards the upper part of the right. Note therefore that this early septal current is also moving away from leads 2, 3 and AVF, the inferior leads. For this reason, it is also perfectly possible to see physiological Q waves in the inferior leads. Remember, physiological Q waves reflect septal depolarization and are limited in magnitude and duration by the advent of depolarization of the main muscle mass of the left ventricle. A physiological Q wave will be no more than 0.04 seconds or 1 small square in duration, and will be no deeper than 25% of the amplitude of the subsequent R wave. Before we move on, one more thing. Note this deflection at the end of each recording strip. This is a calibration box, an internal standard in the ECG machine. It should be 2 large squares in height, indicating that 1 millivolt of electricity yields a 10 millimeter vertical deflection on the ECG paper. This is the standardized sensitivity of ECG recordings. As we'll see, in certain disease situations, it is common for the height of the R waves and depth of the S waves to be abnormal. This can give us useful clinical information, but always look to see if the machine calibration is correctly set before deducing anything from the magnitude of deflections in the leads. The calibration box should also be 1 large square in width. This indicates that the machine is recording at a needle speed of 25 millimeters per second. As we've seen, knowing the speed at which the ECG recording needle is moving over the paper is critical, as it allows us to time the events of the cardiac cycle and to calculate the heart rate. Again, we'll see later that it is sometimes useful to alter the paper speed when analyzing cardiac arrhythmias. However, on this particular ECG, a standard calibration box of 2 squares vertically and 1 square horizontally indicates that the ECG machine is correctly calibrated at a running speed of 25 millimeters per second and a sensitivity of 10 millimeter deflection for every 1 millivolt of current. The ECG we've generated here is a good guide to normality. However, it will rapidly become obvious to you when you start to review patients' ECGs in clinical context that there is tremendous variation in normal ECG morphology in perfectly healthy individuals. Hopefully by the end of this course you will have some grasp of what is acceptable normal variation and what is pathological.